So good evening, everybody, to all the people who've joined in for tonight's webinar. It's the fourth installment of Epilepsy Ontario's Knowledge is Power webinar series. My name is Suzanne Nurse. I'll be hosting and moderating tonight's webinar on behalf of Epilepsy Ontario. I'm the Epilepsy Information Specialist with Epilepsy Ontario. Over the coming months, for the fall and then into the new year, we'll be offering a series of webinars on various topics related to epilepsy. Tonight's session is a webinar called Women, Hormones, and Epilepsy that will be hosted, that will be given by Dr. Melanie Jeffrey. And Melanie, are you on the line at the moment?
I am indeed.
Okay. So for anybody who doesn't know Melanie, I'm going to give a brief introduction about Melanie's background, because I think you'll find that it's quite interesting. Melanie Jeffrey is currently a postdoctoral fellow at Toronto Western Research Institute, where she's working on new animal models of epilepsy, as well as seizures in fetal alcohol syndrome disorder. Melanie works with Aboriginal Studies at the University of Toronto and serves on the executive board of Epilepsy Ontario. Melanie finished her PhD in pharmacology at the University of Toronto in the spring of 2014. In her thesis, she worked with progesterone and its metabolites in models of behavior and seizures, and that will be Melanie's background in that research will be particularly appropriate to tonight's topic, which is about hormones. Melanie has been living with epilepsy herself since 1996. Her seizures are not completely controlled, but she'd like you to know she has far fewer now than in years past. So Melanie has a very personal connection and understanding of this topic, as well as her expertise from her research background. I'm going to switch now to the slides for tonight's session. A few housekeeping items for the duration of the webinar. Participants will be on mute. So if you have any comments that you'd like to add or questions that you'd like to ask, then please use the chat box on your screen. And there will be a formal question and answer period at the end of Melanie's talk. So over to you, Melanie.
Okay, great. Hi, everybody. Thanks for coming. We're going to talk about women.
The conference is now in silent mode.
Everyone, I assume everyone can hear me now. Thanks for coming. Thanks for joining me. Let's get started. Hormones and epilepsy. In the brain, there are areas susceptible to seizures, and they're also very sensitive to to hormones. So these hormones are called neurosteroids in our brain, and they can fluctuate quite a bit. So our hormones affect the EEG, that test we all get done when we're being investigated for epilepsy. You can see the effects of hormones on the EEG, and that was part of my research project. So this slide shows you something from my research. Don't worry, there's not a test at the end. Just to give you an example, though, the black and the red lines are from an EEG recording that we make from an animal's brain. And you can see in the top, there's a seizure-like event, we call it, in the black trace. And the bottom trace that is red is what happens to the seizure-like event when we add progesterone. And you can see that it shortens quite a bit and changes. So part of our research is trying to understand how that happens. Moving on, our outline for today, I'll move right past that into slide 5. First, I'd like to give you a plug for checking or tracking your menstrual cycle if you're still having periods in a seizure diary. You can do this very easily. There's electronic seizure tracking, a paper journal. All you need is really is a thermometer and a pen and paper, but it's much, much easier to use apps on cell phones. If you have a smart enough phone, then you can do that. I find it much easier this way, and I'm much more consistent. It can also be backed up to the World Wide Web every time you check in and plug in your phone, so that the record is never lost. It's also very easy to share with your doctor and share what other medications you're having, if you're experiencing side effects, types of seizures, mood, and your triggers. And it's, like I said, very easy to share. So the seizures and hormones, our hormones affect our behavior, and anyone who lives with a teenager can attest to that. But there are also behaviors that influence your hormones. It's a two-way relationship. So many of the comorbidities of epilepsy, the things that come with it, are also affected by hormones. So changing your hormonal state can have effects on both your mood and seizure control, as well as a lot of other factors, but we're going to focus on seizure control. Hormones are very powerful. Tiny amounts of them can make a huge difference. It makes them difficult to measure, but they affect memory, emotion, how much body fat you have, your bone strength, when you sleep and how, everything you can imagine. Some of these hormones also affect the likelihood of seizures, which is linked to something called catamenial epilepsy in women, as Suzanne mentioned. As neurosteroids, when hormones in the brain, that's how we refer to them. When hormones are in the body, we often refer to them as gonadal steroids that come from our gonads, which is to say ovaries in women or the testes or testicles in men. But in the brain, your brain actually produces steroids all on its own, independently of gonadal steroids. So the two are related, but they're also independent of each other. So all of these complex effects that hormones have on us include effects on reproduction and fertility. Those are the ones we're more familiar with. They also have effects on growth and life stages, which traits are expressed throughout your whole life. You have the same genes your whole life, but how they're expressed changes. It also affects brain function and behavior beyond just seizures, how well we can think. It affects many other things too. The plus is for et cetera, et cetera. Hormone balance is very complicated. Don't be scared of this slide. I just wanted to show you, up in the top left is a cholesterol, which is the precursor for all of these different hormones. They change between each other. It's very complex how this is regulated. So just because we understand part of the picture, we don't understand the whole picture. There are 3 sex steroid hormones that we're going to focus on. There's many, many other hormones, but just for simplicity and to emphasize what we need to, we'll focus on progesterone and estrogen especially. So progesterone is most well known for maintaining a pregnancy and changes to the endometrium, which is, we'll see a picture in a moment, but that's the part of the uterus that a fertilized egg would implant into. And if an egg is unfertilized, that's the lining that is shed in her period. Estrogen is responsible for a lot of secondary sex characteristics in women and a whole lot of other things. We're really only beginning to understand how complex and multi-layered the effects of progesterone and estrogen are in the brain. Testosterone is traditionally known as a male hormone and is responsible for secondary sex characteristics in men, but men and women all have these hormones in differing amounts. The balance of them can change a great deal throughout our life and with different conditions medically. The hormones, as I said before, are tough to measure, and the levels that we do measure in our blood or in our urine, as in a pregnancy test, they don't necessarily reflect what's happening in the brain. We've seen in measurements of brains of animals and humans that hormone levels differ even within different regions of the brain. We don't know how that happens, but we think there are different enzymes involved, and enzymes change hormones into another molecule, into a metabolite. And hormones and their metabolites can have really different effects. Some medications work by blocking or enhancing enzyme activity. In our life stages, hormone levels change throughout our lives. You can see that as we go from birth to teenage years to adulthood, older adulthood, and older ages, there's quite a fluctuation in how many different hormones are expressed. So I'll draw your attention to the green line and the light blue line. The green line is estrogen, and represents estrogen, and the blue line represents progesterone. And you can see that there's quite a bit of fluctuation through teenage years and older adulthood or perimenopause and menopause for women. That's where estrogen varies the most. Progesterone varies quite a bit through our life and then sort of trails off, doesn't have as much variation later. We're going to focus on adults and older adults for this talk. So they can also, hormone levels that change throughout your life can link to your age of seizure onset. So if you start having teenage seizures, then maybe it's linked to some of those hormonal changes that happen when you enter your teen years. In a similar respect, you can have seizures end when you hit your teenage years because something changes and they stop. So you can grow out of them that way. I started having seizures when I was 20 years old, so it was at the end of my teenage years, and that's the way it's been in my family. And they may change again when I get to menopause. We'll see. Hormone levels also can affect which medications and treatments are going to work for you and will work with the fewest side effects. It's important to note that some medications don't work with oral birth control pills and vice versa. We'll talk a bit more about that. But also with life stages and these considerations, you're going to have to think about where you are in your life and what your goals are now and down the road, and your needs and what your dreams are, what your life could be. It's a big decision. So back to estrogen and progesterone. Estrogen is generally pro-convulsive. It causes seizures, and it does that by enhancing a kind of glutamate signaling called NMDA receptor signaling. Progesterone is generally anti-convulsant. Progesterone turns into a metabolite, DHP, and then that turns into another metabolite called allopregnanolone. And allopregnanolone enhances GABA receptor signaling, and that's how it is inhibitory. It's also quite sedative. So during your menstrual cycles, you have different steroid balances. We're going to look at some pictures in just a moment. But those balances affect how excitable your cells are. So that's to say they affect how excitable your cells are. And because your steroids are different in different parts of your brain, it's going to affect excitability of your cells differently. We look at cycle stages to infer hormone changes because we can look at these different clues externally to infer what's going on hormonally. There's a lot of links to seizure susceptibility and intractable epilepsy at certain points in the menstrual cycle. And it could be appropriate to use certain birth control methods to help reduce the hormonal variation and increase the sort of steady state of balance. It could also make sense to increase some of your medications slightly at points in your cycle when you are most vulnerable to seizures, but that requires some quite a few tracked periods and some excellent seizure tracking as well. And this doesn't work for all women, and it's certainly not recommended that you try it. You should talk to your neurologist about this, and it's best to do it with all kinds of data behind you. This is a photograph or a figure at the top. It shows you what's happening throughout a menstrual cycle in the ovary. So in the top left, you can see there's a recruited follicle. The follicle is matures over the course of about 2 weeks, and then we have ovulation when the egg actually leaves the follicle. The follicle then becomes something called the corpus luteum. So the egg has left the ovary, it's heading down the fallopian tubes, but the little body that the follicle was maturing in is left behind. It's called the corpus luteum. And when it starts to degenerate, we see a couple of different physiological effects. So this is one of the ways, although we can't see a physical change at ovulation, it's one of the ways that we can infer when the ovulation is happening. It's easier to tell when you're menstruating than when you're ovulating. one of the ways that you can tell if you're ovulating is your body temperature. We'll talk about that in a minute too. You need to be very careful about how you track it. But you can see that the hormone levels rise and fall. So third from the top, around here, the hormone levels rise and fall right around ovulation. That's the important phase of the cycle for hormone changes, and those changes are what we're looking for with respect to catamenial epilepsy. So the blue line is estradiol, which is just a human form of estrogen, the most dominant one. The red line is follicle-stimulating hormone, and this is green line is luteinizing hormone. We're not going to worry about those tonight. But progesterone is this black line here, and you can see that it goes on a slow peak after ovulation and before menses, or before the period starts. If we go down to this level, the bottom part of the slide, it sort of gives you an idea of what's happening in the endometrial lining. So when you're menstruating, that lining is shedding. That's what you see when you menstruate. And then over the course of your cycle, it builds up again to be ready in case there is a fertilized egg to implant. Shortly after ovulation, if there's nothing implanted, then this lining will start to degrade again. It'll start to go away. But however, if the egg is fertilized, if pregnancy, fertilization occurs, then this structure is essential for the egg to survive, for the pregnancy to survive. So this is a representation of 3 different types of catamenial epilepsy. One of them is the perimenstrual type, so this C1 here. Please take note that this is a cycle, so it's not really a straight line. It should be more of a circle. So perimenstrual is here as well as here. We're talking about the same period of time, just different ends of it. So the periovulatory type, during ovulation, that's when women are vulnerable. The perimenstrual type and the periovulatory type go together often. Women can have both types or just one or the other. So you can see that at the periovulatory type, where that peaks, there's a progesterone is lower and estradiol is peaking quite a bit. During the perimenstrual type, you see the same thing. Estradiol is higher and progesterone is lower. There's a third type of catamenial epilepsy, which is not the clearest from this diagram, and it's called C3, the inadequate luteal type down here. So all the way from the beginning of the ovulatory phase to halfway through the menses phase and the menstruation, women can be vulnerable to seizures if they have that inadequate luteal type. And we'll talk a bit more about how that happens. A few more slides. This is a diagram of progesterone levels measured in blood for women who have ovulatory cycles. So right here at the red line is where we have ovulation. The blue line is where menstruation occurs. And these are all averages, so that has to do with the gradation of the colors involved. But you can see that progesterone rises and falls between ovulation and menstruation. Progesterone happens to rise and fall between ovulation and menstruation. Estradiol, or estrogen, rises before ovulation and then again before menstruation. So these chemicals don't move and change at the same time or at the same rate. So when we're looking at body temperature and how body temperature relates to all this, the ovulatory cycles, I just showed you pictures of estrogen and progesterone levels in an ovulatory cycle. Higher levels of estrogen are associated with a lower basal body temperature. Higher levels of progesterone are associated with a higher temperature. A lot of women with epilepsy don't necessarily have ovulatory cycles. They can have anovulatory cycles. And when you have an anovulatory cycle, no egg is released. You don't ovulate. And the progesterone surge that we saw 2 slides ago does not occur. So the basal body temperature is much more uniform. It doesn't change as much. And you're missing a lot of the cues, such as like changes in your vaginal discharge and breast soreness and mood changes are not the same in anovulatory cycles as they are in ovulatory cycles. This diagram shows you an ovulatory cycle at the top and the changes in body temperature, basal body temperature, over the course of the cycle. So menstruation begins, the follicular phase, when that follicle, that egg is developing, and then just at ovulation, you see a drop and a rise in temperature. And this is what you're attempting to pin down when you're trying to track your basal body temperature with respect to your cycle. Trying to find that point of ovulation is between this low and high point here. And then throughout the luteal phase, when the progesterone levels are higher, you can see that the body temperature is higher as well. So you have a range of about 1 degree Celsius in an ovulatory cycle. In an anovulatory cycle, we don't have that biphasic or 2-stage temperature. It's called a monophasic profile, which means it only has one real shape. Instead of the top, which has 2 distinctive phases, the bottom is much more uniform. The range of basal body temperature is much lower. It's half of what it is above. Also with anovulatory cycles, it's some women menstruate, some don't. It's not known, you can't tell if you're having ovulatory or anovulatory cycles necessarily by menstruation, but ovulation doesn't occur, and that's why we don't see these changes. A warning about checking your body temperature: it varies a great deal during the day. Your lowest body temperature level here at 5 a.m. is quite different from your highest body temperature here around 3 in the afternoon, 4 in the afternoon. So it's very important that you, when you're measuring your basal body temperature, you do it at the exact same time every day and as early in the day as you can. If you sleep in on a weekend and take your measure at 10 a.m. instead, it's really not accurate to be part of your basal body temperature picture because things rise so quickly in the morning. So if you usually get up at 6, that's the best time to take your temperature, and you should do it before you get out of bed and start moving. So you want to keep the thermometer right beside the bed. Some women use this in terms of maximizing their chances of getting pregnant. They use similar principles. However, this is really not an effective method of birth control at all. So it's definitely not recommended for birth control. That red arrow on the right is showing you how much variation there is in general in the cycle, in the body temperature during the day. All diurnal means is during the day. This little blue arrow shows you how much of a change we're looking for with respect to ovulation. So you can see that the variation during the day, the red arrow, is much larger than this little tiny window that we're looking for, the blue arrow, to see where we are in a cycle. So it's very important to always measure at that same time of day, every day, so that you can see this much variation. When you're tracking your cycle, if you have ovulatory cycles, you can estimate hormone levels. And you do that by tracking changes in your body temperature, but also in your cervical mucus or the discharge that you see often in your underwear. This is a very simplified diagram, but shows you that when you menstruate, you're not fertile, or theoretically you're not fertile. And your fertility days are maximized after menstruation ends and after just when ovulation occurs, And then after the shedding of the endometrius begins, but the corpus luteum is still degrading, you're infertile. But this is an average. This is not the same for every woman at all. And particularly women with epilepsy can have altered profiles. So although the classic model is a 28-day cycle, your cycles could more likely be between 26 and 35 days. Your cycles could be very irregular. It's really not the same for everyone, and so it's important to chart your own. I've told you about the basal body temperature, and you can see that at times when the body temperature is high, here, the progesterone is high, but this is only for ovulatory cycles, not for anovulatory cycles, okay? I'd like to draw your attention to this little bar line at the bottom of the graph, which points out menstrual follicular phase when the follicle is developing, ovulation or the ovulatory phase of the cycle, the luteal phase when that corpus luteum is degrading, and then back to the menstrual phase again, right? And around to the front. This is only true for ovulatory cycles, though. So once again, at the ovary, you can see the body temperature is relatively stable but lower as during the follicular phase while that follicle is maturing. And then at ovulation itself, that temperature rises. So the average temperature rises quite a bit. And this is the chance, right around ovulation is when a woman would, if you're trying to get pregnant, that's the optimal time to be sexually active, to get pregnant. A lot of pregnancy tests measure something similar. They also measure things like this luteinizing hormone in our urine. And there are basal body temperature kits for pregnancy planning that are very sophisticated, very expensive, but you can do this with a plain old thermometer at home. So when you're looking at tracking ovulatory cycles, looking at discharge, during that early follicular phase, right after your period, often women have dry days, so almost no discharge at all right after the period ends. Closer to ovulation in the late follicular phase, the amount of discharge increases. So it's noticeable, it's wet, it's transparent, and it's elastic enough often to stretch between a couple fingers, an inch or so, and has a texture more like an egg white, a raw egg white. When you get just beyond ovulation into the early luteal phase, the discharge starts to change. It becomes more pearl white or slightly yellow. And the texture, instead of being that raw egg type texture, is more like body lotion. Later in the luteal phase, as you get much closer to your period, the discharge may become more sticky or even lumpy, but you'll notice a change when you start watching for it. A bit more about discharge. If you become pregnant after you ovulate instead of entering a luteal phase, you'll still see a thick discharge. It might be different, but it will be a thick discharge. So this is not a good way of knowing whether or not you're pregnant. Also with discharge generally, a thick or lumpy or thick and lumpy discharge after unprotected sex is perfectly normal. But any kind of abnormal discharge can indicate a health problem, and you should talk to your doctor if you're concerned and talk to them about how you're tracking and how you're doing tracking things. So once again, we have this ovulatory changing cycle. We see the range of body temperatures, right? In an anovulatory cycle, well, we don't see that range of temperatures. So anovulatory cycles happen to be more common in women with epilepsy. They're irregular cycles, and often they're longer than 35 days. In most women, one or two anovulatory cycles a year are normal while you're in your reproductive years. More than that, however, are not. So if you're having more than 2 anovulatory cycles a year, it may indicate that things aren't quite going right, or at least normally. There's not, as I mentioned, there's not the cyclic variations in the discharge or in the basal body temperature. And there's less hormonal variation than in ovulatory cycles. And that's part of the reason why the seizure vulnerability changes. You likely will have few or no periods, which no period is called amenorrhea. And you may have periods with typical bleeding or atypical bleeding. Maybe they're very heavy, maybe they're very light. But there are a few different ways that you need to investigate to confirm this. So in an anovulatory cycle, as I said before, if you don't have that surge of progesterone, that's what changes things. That's what makes it different for women having anovulatory cycles. They don't have that surge in progesterone, so it's called an inadequate luteal cycle because there's not enough happening. The corpus luteum isn't degrading and causing that surge in progesterone. We see just that monophasic body temperature, no changes in the discharge. So in this inadequate luteal sort of phase, there's that surge of estrogen still, but not of progesterone. So that can make some women vulnerable for most of their cycle, unfortunately. Days 20 or 10 to 28. Day 1 is second or third day of menstruation. So that means that these women could be vulnerable if they're having anovulatory cycles during a huge phase of their cycle and what we would normally call ovulatory luteal and menses, but not during the follicular phase. So to look at that again, during the follicular phase here, the inadequate luteal type of catamenial seizures, you're not vulnerable during this phase. You are vulnerable during the ovulatory, luteal, and to a lesser extent, the menstrual phase of the cycle. Women who have ovulatory cycles can be vulnerable here when the spike of estradiol happens and progesterone is still rising. They're not vulnerable in between, but they can be vulnerable here, right when estrogen spikes right as menses begins, right as your period starts. In menopause, epilepsy can alter the timing of menopause, when it occurs, how it occurs, and some women with epilepsy experience a premature menopause. It's important if you're concerned about this to talk to your doctor because whether you're experiencing premature menopause or you're just having ovulatory cycles could make a big difference to some of the decisions that you're making in your life. So during menopause, we see a drop in both hormones, both progesterone and estrogen, but progesterone drops quite dramatically at first, and there's a phase of menopause where your estrogen dominates. It's called estrogen dominance period. That can mean a higher seizure risk. You have to remember that there's not just these two things going on, not just estrogen and progesterone. There are so many other things happening in your body as well, whether you're going through menopause, whether you're premenopausal, whether you're postmenopausal. And this is just one aspect of that. So you need to keep that in mind, have that sort of balance view of all of this. Tracking your seizure and your cycle with their diary or with the seizure app is very useful when you go to talk to your neurologist or your doctor about these issues. With respect to menopause, hormone replacement therapy is associated with an increased risk of seizures, so it's really not recommended for women with epilepsy. It decreases, hormone replacement therapy can decrease the level of some anticonvulsant drugs too. So if you're going through menopause or you've gone through menopause and then start hormone replacement therapy, that can change how well your anti-epileptic drugs are protecting you. Hormone replacement therapy isn't as common as it was a few years ago. It is, associated with cancer and some other nasty things. And that's part of the reason that we know it's so dangerous to prescribe hormones, even the hormone levels that you had before at a different time in your life can definitely increase your risk for certain kinds of cancers. This is a great photograph from a website called Menopause that really shows how estrogen and progesterone change. This is showing your blood concentration of the hormones. So what's going on in your brain is a little bit different, but they are related to each other. They'll affect each other. So in the red line, we see estrogen. Here, we're at perimenopause between these two gray lines. So estrogen stays high through perimenopause, or around when menopause is starting to happen. But look at our purple line. Progesterone drops quite dramatically. So that puts us in a similar kind of position as we are with some of the catamenial epilepsies, where estrogen is high relative to progesterone. So this is the estrogen dominance phase in perimenopause. And during menopause itself, you have these incredible variations in estrogen levels, but your progesterone levels stay very low. Often HRT, or hormone replacement therapy, seeks to even out some of these drastic changes. These changes cause all kinds of the symptoms, that uncomfortable symptoms associated with menopause. But also, this is a normal process that needs to occur for you to get to postmenopause, and then things will even out again. Very briefly, I'd like to talk a bit about reproductive health and contraception, because it has so many ties to hormones. There's a great information source online, the website I've listed here. There's an epilepsy birth control registry, which is open to Canadians. It's based in the United States by a terrific researcher and doctor. It's an excellent information source. But if you could enter in the registry, it only takes a few minutes. You indicate what kind of birth control you've been on and what kind of anti-epileptic drugs you've been on. And they're trying to create, for the first time, a real registry of what's working for women with epilepsy and what's not with respect to their reproductive health in contraception or birth control. So if there's anyone you know that you can encourage to do this, it doesn't cost us anything, and it will help women in the future. So a little bit about reproductive health. Some AEDs or anti-epileptic drugs decrease endogenous hormone levels, or how much hormone levels you have naturally in your body. So that can have a lot of effects on our reproductive health. Many. The partial epilepsies or seizures of focal onset are most associated with reproductive health issues. They're also the most refractory to treatment, so it's difficult sometimes to separate out whether it's because they're more difficult to treat and that causes reproductive health issues. We're trying more medications for these people, sometimes at the same time. That can lead to more side effects, some of which are reproductive health issues. So just because you have a partial epilepsy doesn't mean that you're going to have reproductive health issues. However, if you have partial epilepsy, you are more likely to have polycystic ovarian syndrome. I actually have this one. And you can see on the picture that they take of your abdomen, it looks like a string of pearls around your ovaries. And those are the polycysts. Those are those many cysts. So that can be common in women with epilepsy in general, but especially women taking valproate as their medication. Valproate has some pretty dramatic effects on your reproductive health, and that's why it's not the first recommended medication for women who are in their reproductive years. PCOS, all it means is that after you ovulate, the follicle develops abnormally. So that changes your hormone balance, as I've talked about before. But it doesn't just change your neurosteroids, you're changing your gonadal hormones, which have much more melodramatic effects on the body. And very briefly about birth control, since most medications alter your hormone balances, changing birth control could also change your seizures. If you switch from one method of birth control to another, or even one oral contraception to another, then this is going to change your seizure pattern. So estrogen-containing birth control therapies are generally a bad idea because estrogen is proconvulsant. The progesterone-based therapies are less likely to make your seizures worse. However, it's really important to know different oral birth control pills have different combinations of estrogen and progesterone, so you need to be very aware of which one makes sense for you to try. And in general, most oral birth control pills conflict with anti-epileptic drugs. Neither work very well with each other. So your anti-epileptic drugs can't work as well when you're on oral birth control and vice versa. That has to do with drug metabolism. So in all of this, planned pregnancies are very important, so birth control is very important too. Just because you feel discouraged about finding birth control that works for you, don't give up. Some women with epilepsy find Depo-Provera, which is the every 3 months injection, works for them. And also very briefly about pregnancy and a little bit about bone health. There's going to be much more detailed webinars in the new year that are going to be specifically about pregnancy and lactation in epilepsy. And they're huge topics, but I'm going to touch on them briefly here with respect to hormones. Important to know, most women with epilepsy have normal and healthy pregnancies. The incidence of adverse events in pregnancy is not much higher at all for a woman with epilepsy than a woman without epilepsy. The most dangerous thing is for medications to be withdrawn. When that happens, you have a huge spike in your risk for seizures. But also, as you're gaining weight, as you're pregnant, you may need to increase how much medication you're taking because you're gaining weight, first of all, but also because your metabolism is changing through the course of your pregnancy. During the course of your pregnancy, hormones change quite dramatically. That's part of the reason in the first 3 months you feel so sleepy and all kinds of different effects on mood as well during the pregnancy. So all of this, what all this means is seizures are most dangerous to mom and baby. And if you withdraw medication or don't adequately increase it for the pregnancy, then that can have the worst outcome for you and for baby, or for mom and for baby. And this is why it's very important in your choice of anti-epileptic drugs as a younger person, even if you're not planning pregnancy anytime soon, you should be choosing your anti-epileptic drugs so that it is possible. It will be very disruptive for you if you need to change AEDs when you're starting to plan pregnancy. It takes a long time to change AEDs. It's better to do something when you're not on a 9-month timeline. And also, the benefits of breastfeeding do not outweigh the potential risks of AEDs in breast milk. We have not seen any evidence of adverse events for infants or negative effects for babies who are breastfeeding from a mom taking anti-epileptic drugs. We do know that breast milk is so incredibly important for normal development for infants. And that's been very well documented. And so if you can breastfeed, it's best to breastfeed and not worry about the risk of anticonvulsant drugs in your breast milk. So planned pregnancies are important, not just so that you can be prepared with your drugs. There's also a fair amount of supplementation that should be done. And some of you may be already on some of these supplements as just in case the pregnancy occurs, because the last thing that you want when making that decision is thinking about birth defects. So supplementation with folate, which is a B vitamin or folic acid, is very common. It prevents, and vitamin K as well, and they can prevent some known birth defects. They're very rare, but they can happen, and so the supplementation with folic acid in particular, but also vitamin K, is important before pregnancy as well as during pregnancy. You should plan for medication changes during pregnancy, but also be prepared for what happens after baby comes. like taking care of your little ones safely, what you might need to do to, to plan to change the baby's diaper, to be ready to handle everything safely. And lastly, very briefly on bone health, vitamin D, which we've all heard of and is in our milk, it's also a hormone, so it has lots of effects on our body. It's generally low in people with epilepsy, and certain drugs can also affect how vitamin D metabolizes and how it affects bones. Supplement studies have been inconclusive, which means that supplementing your vitamin D with something from the health food store in a pill form is not necessarily helping. But we do know that the people on epilepsy tend to have osteoporosis. So let's take a look at that. In the diagram on the bottom, osteopenia means you're getting poor in bone. Normal bone looks like this. It's a nifty little matrix. And osteoporosis means your bones have holes in them, basically. And you can imagine if this is normal bone, then with osteopenia and osteoporosis, it's much easier to break bones. This is particularly the case with the hip bone. And also menopause generally decreases your bone strength. So there are some important prevention things to think about for your whole life. One of them is the choice of anticonvulsant medication. That may change depending on your family history too. You also need to exercise. If you spend a lot of time at home or spend a lot of time socially isolated, you're probably not getting much exercise. Nutrition and monitoring or getting your bone mineral density tested is also very important. But also with respect to those of us who have seizures, the trauma itself of seizures, and there's a mild incoordination associated with AED use, this leads to more falls generally. So that can also increase the chances of you running into something that could cause a bone break compared to other people. I'd like to talk a little bit about something called mind-body concepts. This is related to hormones in so many ways. Generally, we're talking about a kind of guided relaxation and stress reduction and awareness. We take behavior and we change processes in our life. We change things that feel outside of our control, that are leading to a poor quality of life. We identify triggers and strategies to help decrease the triggers, and this helps increase a sense of control. And it also helps you avoid things that aren't good for you. And you must be emotionally and spiritually and socially and physically healthy. Like for those things must be balanced for us to be healthy and improve our seizure control. And this isn't something that comes easily to any of us. We need help often to find our way through this. I certainly did. So behavioral therapies and modifications are very promising. They're very low risk, especially compared to different drugs. And some people have become seizure-free or at least been able to decrease their medications after they've engaged in some of these therapies. It's a lifelong thing. It's not something you do once and change. There's lots of different ways to do it. What you choose will depend on who you are and what works for you. Talk very briefly about meditation. Breathing is the central part of this and bringing about a sense of calming the mind and relaxing the body. It's safe and simple, but it's very effective. How this interacts with hormones is that it affects something called your neuroendocrine system, and stress affects all of that too. So of course it's going to interact with your seizures. You can see when people meditate how it affects their EEG and changes hormone levels in their body and many other body systems. So in terms of what else you can do with some of what I hope that I've been able to share with you today, you can use what you know about hormones and brain to reduce your risk of seizures, but also help with other health problems generally. Use a seizure tracking app on your smartphone or a diary and try and track your cycle too. And talk to your doctor about your seizures and cycle patterns, and also talk about your bone and reproductive health. And as a patient, you need to exercise some agency there and make sure that that happens. You can use behavioral techniques to reduce chronic stress and improve mind-body awareness. and that will also help with your hormone profile and your seizures. But to do that, you need to give yourself time and space to engage in healthy behaviors. Sometimes life is so crazy busy, it can be tough to take time to do what we need to do to be healthy, but that's something you need to make space and time for in your life. And go on, take your next steps. Don't give up before you even try, and know that there are many people on this journey with you. Thank you very much.
Melanie, thank you so much for all of the information that has been included in this presentation. As anybody who's participating in tonight's webinar probably knows, this is a topic that often doesn't get a lot of attention, and discussion about how hormones can affect women with epilepsy across the lifespan is something that is really important information for people to have. One thing I'd like to let people know is that this webinar is being recorded. So since there is a lot of information that's been in this webinar that Melanie has shared with us, you may want to be able to refer back to some of these different slides and to be able to have a look at them again, and you will be able to do that by going to Epilepsy Ontario's website, which is epilepsyontario.org, and we'll be posting this webinar for people to view afterwards, so the information will be available. Now, for anybody who may have questions about the material that Melanie has presented tonight, by all means, you can type your questions in the chat box that's on your screen, and I'll let Melanie know what your questions are. In the meantime, one thing that I'd like to make people aware of, Melanie has mentioned a couple of times throughout the webinar tonight about the importance of tracking seizures. And it's particularly important if you feel that there may be a pattern to your seizures that could be linked with your hormonal cycles and variation in your hormones throughout your menstrual cycle. And on Thursday, November 20th, Epilepsy Ontario will be hosting a webinar called Tracking Seizures. It will be delivered by Rob Moss, who's the creator of SeizureTracker.com. And so it'll be relevant to the material tonight in terms of understanding how to track your seizures. So it'll be an addition, a very good addition to this information this evening. Also, as Melanie mentioned earlier in her talk, we are planning a webinar in 2015 about pregnancy in terms of what things women with epilepsy should be aware of in terms of pre-pregnancy planning, the impact of epilepsy on pregnancy and things people should know, and also considerations for postpartum. So that'll be an upcoming webinar in 2015. So if anybody has any questions, you're welcome to type them into the chat box, and I'll pass them along to Melanie. In the meantime, Melanie, one thing that I'm wondering if you could perhaps share with the participants in the webinar would be many women may feel that there could be some sort of pattern to their seizures. They may have more seizures at some stages of the months than at other times. But how would they go about really knowing whether what they are experiencing is what would be referred to as catamenial epilepsy?
The important thing to remember that catamenial epilepsy is just a way we have of naming something. It's a way that we refer to the patterns associated with your menstrual cycle. If you think there's a pattern, you need to start tracking it to see if there is a pattern. Sometimes we feel like, oh, my partner said the other day, you're going to have a seizure soon. I can just smell it. I said, really? You can smell it? That's fantastic. And we'll see if he's right. But unless we were to write it down every time he said, I think that you're going to have a seizure, we wouldn't know if it was working or not. So you need to track it to know if there are links in your cycle. You need to track your cycle, and you need to track your seizures. So catamenial epilepsy officially is an increase of 2 or more times the amount of seizures at that phase of your cycle. And I see a question.
Yeah, so many physicians and doctors aren't informed about medications and pregnancy. Is there a resource for doctors so that they aren't taking women off their seizure medications, when somebody's anticipating a pregnancy or has become pregnant?
There's an excellent resource that just came out that I hope all doctors read. Hopefully they will. We'll see. But it's a Women in Epilepsy book. It just came out in the past year, and it's very good. I'm looking for the title of it right now, Suzanne, but I'm not seeing it.
Okay. If you happen to come across that just before we finish the webinar this evening, you can share the title of that book.
Okay.
Then
it's Women in Epilepsy or something to that effect. And Cynthia Harden is one of the authors, and she's an expert in this area. Basically, pharmacology is complicated, and not every doctor knows everything about pharmacology. There are resources that they can read to sort of bone up on it, to learn about it. But even your neurologist, this is a very complicated decision, so it might be something you want to talk to an epilepsy specialist about. And you really would also like to include a gynecologist obstetrician who may have a different perspective that can bring in. You need those people to work together in a team.
And
does that help?
Comment, yeah, I think that is very helpful. And we can put a link to that particular resource on our website as well. There's a comment from one of the participants this evening who says that they found out they were pregnant after they had had their first tonic-clonic seizure. And some people may refer to tonic-clonic seizures by the older terminology of grand mal, may be familiar with that term. This participant said they were automatically then referred to a high-risk OB-GYN, and through their experience, they would suggest that everyone finds a high-risk OB-GYN as hopefully they're more knowledgeable than regular doctors. So I hope by that comment that this participant found that experience was good for them, and that they had good care throughout their pregnancy.
Hope so. And there are some really excellent OB-GYNs out there. So we'll see if we can talk to you. But definitely, if you can be proactive about it, then go talk to this person about birth control. Go talk to them about birth control and interactions with your medication. And so long before you're at the stage of pregnancy, even before you're perhaps planning pregnancy, you can be talking to this person and finding out more. I've had some excellent experience with the OB-GYN that I see, but he's very experienced. And now we have a daughter, 3 months old. Birth control. Birth control can lower seizure medication. It depends really which one you're on. So there are some that interact with each other, like where birth control actually lowers the level of anticonvulsant drug in your bloodstream, so you need to take more of it. And then there's others that don't. So it really depends. And also it's an individual thing. So what's working for you might not work for somebody else, and vice versa. Certain kinds of, so depending, there's about 30 different anticonvulsants on the market right now. And I don't know how much birth control, but there's got to be upwards of a dozen different options with oral contraception now. And so how those things interact is going to be really available too, or really variable, I should say, too.
So one of our other participants said, is there a list of doctors available in Ontario that have in-depth knowledge in this area?
I don't know, although I would say that any of the specialists who are epileptologists, which is to say a neurologist who specializes in the treatment of epilepsy, will have more insight into this than a general neurologist, where people with epilepsy are not the majority of their practice. But also, if you're dealing with a high-risk OB-GYN, then that's going to really help. You should be able to find a lot of those people work at teaching hospitals, like the Toronto Western Hospital, or at Mount Sinai Hospital, or at other hospitals. You should be able, also there's some pretty nifty tools you can look up about doctor reviews online that are pretty good.
And then also people, if you're looking for information about where there are epileptologists in the province of Ontario, you can always contact us at Epilepsy Ontario, and we can give you information about there are comprehensive epilepsy centers that have neurologists on staff who are epileptologists, so they have additional training and specialize in the treatment of epilepsy, and we can share information with you about where those centers are. And we also have materials that we can give you that you can take to your physician. So if you're not currently seeing an epileptologist, we have information around guidelines for treating women with epilepsy, and we can give you those guidelines that you could share with your physician.
Yeah, they're great tools.
So another question, sorry for all the questions, so that's not a problem at all. We're happy to get your questions.
No, not at all.
So what exactly does an MRI show in patients that have epilepsy?
So this is a big question because it can show in symptomatic epilepsies, a certain kind of epilepsies, where we see a structural change in the brain. It's something you can see on an MRI. So often we see like a kind of atrophy or a sort of shrinking of a little area. If there's been a brain injury and some scarring, then we can see that on an MRI. We can see structures on an MRI. So we can't see how things are functioning. So I'm one of the people who has a normal MRI. My MRI doesn't show any areas where things could be causing seizures, but it's the functioning of my brain that is the problem, which is always fun for my family to make fun of. The extent and range of my brain damage. But it's not something that you can see on an MRI. It's something that you have to see in terms of how the network is working instead of what structurally might be wrong. I hope that helps.
And that is something that would be seen then sometimes on an EEG. So an MRI might be normal in some people with epilepsy, but there might be changes that could be seen on an EEG that's going to measure function. And then in between seizures, some people with epilepsy would have a normal EEG as well.
Yeah.
So one final question before we finish this evening. So does it show when you've had a seizure recently, or just the area or function of the brain that's causing the seizures? And this participant has an MRI coming up in a week, so they're looking for some information about what they might be able to expect.
Well, with the MRI, it likely won't show if you've had a seizure recently. That's more of an EEG kind of thing, because we can tell from the EEG by the signals that are there. If usually right after you've had a seizure, you're less likely to have another one soon, and there's biological reasons for that, and we can see on the EEG when that sort of inhibitory phase has begun. But most of the time your EEG is normal, and then just for that tiny like seizure period, that's when you see the abnormality in the EEG. So it's not going to show whether or not you've had a seizure. It's going to show the area of all the different areas of your brain. It's an enormous document, actually, when you look at all of the different pictures. They may be able to infer what part of your brain might be causing seizures, but they have to investigate it next with the EEG and see if something structural is actually tying in to a function that's happening. So that's why the MRI and the EEG together are such important tools.
So with that, Melanie, I'd like to thank you so much for all of the information that you've shared this evening. It's been really, really valuable, and this will be a valuable resource that will be added to our website as well, so that anybody who's interested in this topic about how hormones can influence brain function and have a role in seizures for people with epilepsy will be able to refer to it. I'd like to thank everybody who's been online with us tonight for participating in tonight's webinar. This is the fourth in a series that is offered through Epilepsy Ontario most months except for the summertime. So look for upcoming webinars this fall, including the Tracking Seizures webinar in November. If anybody has ideas or suggestions of things that they would like to see in upcoming webinars, please let us know. And I'd like to thank everybody for participating tonight, and have a good evening.
Thanks, you too. Thanks, Suzanne.
Bye-bye.
Bye.